Good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Madam Dr. Urvashi Singh, directors and teams from NIRT and NTI, STOs, directors of STDCs, faculty of medical colleges, district TB officers, medical officers and others. A very warm welcome. Introducing the faculty from NITRD, I am Dr. Neeta Singla and I am Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is the senior pulmonologist at NITRD. Now I request our Director Madam, Dr. Manpreet Bhalla, to give her introductory remarks.
Thank you, Dr. Neeta. Good afternoon, everyone, and welcome to today's Difficult to Treat TB Clinic, which is held in collaboration with the Central TB Division and National Task Force. And we have with us Professor Dr. Urvashi B. Singh, DDG TB, and she's always supporting us with her guidance as always. And we welcome you. This session is the first of a series of on the topic of BPaLM case series. So I think we are beginning with this session, and as Dr. Neeta has said, we have STDCs, directors, DTOs, medical officers, and faculties from medical colleges. So I hope wish to have a good. There should be active participation, and we look forward to good deliberations. Thank you.
Thank you, Dr. Manpreet. Now I welcome our DDG ma'am, Professor Dr. Urvashi Singh. Her presence is a great motivation for all of us. We always look forward to her guidance in these clinics. I request her to give her address. Over to Dr. Urvashi ma'am. Dr. Urvashi ma'am, if you can hear us.
Ma'am, DDG ma'am is in another meeting.
Okay, so she can join us whenever she's able to join. We'll look forward to it. Thank you, Dr. Siddi. Okay, so since ma'am is not able to join, we'll hear from her as soon as she's able to. So in our series of different states discussing their cases, today the case is from GHTM Tamram, Tamil Nadu. The case presentation is by Dr. G. Prakash, who is a postgraduate in MD in Department of Respiratory Medicine, Government Stanley Medical College, Chennai. The state expert is Professor Dr. P.M. Ramesh, who is head of the Department of Respiratory Medicine and is also the superintendent of GHTM Tamram. And the national expert is Dr. Alpa Dalal. She's head of the Department Pulmonology in Jupiter Hospital, Thane. And the clinic expert will be Dr. Singla, who's consultant with NITRD. So now I request Dr. Ramesh to present the case.
Thank you, madam. Is it audible, ma'am?
Yes, sir. So today we have series of cases. It's not only one case. Dr. Ramesh is going to present a series of cases who have been put on BPAL regime.
Thank you, ma'am. And first of all, I thank Rupak Singla sir for given this opportunity. So last week we conducted in our state regarding our BPAL case series. So sir has joined the sessions and given the valuable inputs. Now sir has given the chance to present our case scenarios in the national level. So thank you for that, sir. So from cancel. From January 1st onwards, we initiated the BPAL regimen, sir. So far we initiated 14 patients. Here we presented some of the cases. We initiated the BPAL regimens as per the CTD guidelines. Now I request our postgraduate students, Dr. Rakesh, to present the cases, sir. So is the presentation started from your side, sir?
Okay, sir, we are starting.
Yes. Proceed.
Good morning, everyone. I'm Dr. Rakesh, Junior Resident, Stanley Medical College. Today, we'll be dealing with the case of BPaLM case series. We would like to share a few cases we have started so far. First case, a 65 years old male who came to our OPD with complaints of cough with expectation for 2 months, with evening rise of temperature and a significant loss of weight. We have proceeded with chest X-ray and sputum reports. Sputum reports turned to be resistance. We have given samples for LP and midget culture. Next slide.
I think we need to mute the participants. So many participants, we are getting a background noise coming.
May I proceed, ma'am?
Yes, sir.
Chest X-ray shows left upper zone heterogeneous obesities. Patient has no comorbidities. Patient was an alcoholic for the past 20 years. He has no prior ATT history or exposure to any bedaquiline, predominant or linezolid drugs. We proceeded with the pre-treatment evaluation. We obtained cardiology and after opinion since we are starting the patient on bedaquiline and linezolid. Cardiology shows no conduction defects. QTC was found to be within normal limits. After opinions, both the fundus were normal. Routine investigation shows hemoglobin 13.2, which is a normal limit, platelet in 3 lakhs. RFT, LFT were in normal limits. We proceeded and started the patient on BPaLM. Bedaquiline 400 mg OD and predominant 200 mg OD. Linezolid 600 mg OD and moxiflux 400 mg OD. We have observed the patient for the 14 days. We have monitored with serial QTC daily, which was found to be within the baseline limits. And we have repeated investigations, which was found to be within the normal limits. Patient has no new complaints. He has presented with abdominal pain after 14 days to our OPD. Previous slide, please. Previous slide, abdominal pain. He has presented with abdominal pain. We have admitted in the patient and take a CT abdomen on this patient, which was found to be normal. We proceeded with general surgery opinion. General surgery opinion was found to be normal, and the patient they told to be under observation. Patient symptomatically treated with the PPIs and other supportive measures. Next slide, please.
Sir, shall we give comments at the end of each case, or shall we proceed all 8 cases together, sir?
I think, sir, we will all note down our questions for the case, and maybe we can have a discussion case-wise once you finish it.
Once we finish.
So
okay,
so we all note down our queries case-wise, or we can put it in the chat box. And then once you finish presenting, then we'll take case by case.
Okay. Since predominant we are suspected to cause pancreatitis, we kept the patient under observation for 5 days. Since the patient improved with symptomatic measures, we discharged the patient and kept under follow. Second case, a 37 years old male came to our OPD with complaints of cough with expectoration for 1 month with evening rise of temperature and loss of appetite. We proceeded with sputum analysis and chest X-ray. Next slide. Sputum reports showed CBNAT MTB detected resistance. First line LPA, INH high level CAT-G resistance and rifampicin resistant. Second line LPA, fluoroquinolones resistant, and second line injectable sensitive. Hence, we categorize the patient as pre-XDR TB. And we have proceeded with BPaLM. Since the patient has no exposure to previous history of any bedaquiline or linezolid, we started the patient on bedaquiline BPaLM regimen. Next slide, please. Chest X-ray shows bilateral upper zone and left mid-zone, lower zone heterogeneous opacity with evidence of cavitation. Next slide. The patient has no comorbidities. He was a smoker and alcoholic, no prior ATT history. We proceeded with the pre-treatment evaluation. Cardiology and after opinion were found to be normal. Pre-treatment HB was found to be in 10.8, which was not under criteria for not starting linezolid. Hence, we proceeded with BPaLM regimen. Next slide, please. Next slide. Yes. BPaLM was started on Feb 1, 2025. We have monitored the patient with serial QTC daily, and the baseline investigation were repeated. They are found to be within normal limits. Patient was tolerating ATT. No new complaints were observed. Hence, patient was discharged and kept under follow-up. No adverse reaction noted.
Dr. Ramesh, if you permit, I think we can take after every 2 cases.
Okay.
Any discussion, anybody has any question?
Okay, sir, no problem.
We can do that. So, Case
So,
these two cases are open for discussion. Any questions anybody has, they can ask.
I think the case one had only RIF resistance, and case two was a pre-XDR, which is never treated before, and this patient has RIF resistance, INH high-level resistance, fluoroquinolone resistance, and on liquid culture has pyrazinamide resistance also.
so regarding first case, ma'am, we encountered patient had abdominal pain. And we got opinion from both the medical and surgical gastroenterologists, and they found clinically there is no significant pathology found, and even the ultrasound and CT abdomen were normal only. So just we hold the medicines for 5 days. We hold almost all the drugs. We just hold it for 5 days, and we given this because patient has unbearable pain. Even he is not able to lie in the bed. So we just hold the medicines for 5 days. Then we given the symptomatic treatment. At the end of 5 days, all drugs has been started simultaneously. But patient this time tolerated very well, no further issues. So on inquiring regarding this in our concerned HODs and other things, they suggested regarding the looking for pancreatic enzymes. So during that abdominal pain time, we have not evaluated regarding any pancreatic enzyme levels. We have not seen, but after the review, we seen it is found to be normal. So that is one point which is noted. We also look for pancreatitis also during that abdominal pain, but at that time we missed. So after that only we evaluated for that also.
So,
Right.
can I ask something?
Sure, Dr. Alpha.
Yeah, so first case you started on BPaL regimen in December. This
And
already
January 1st, ma'am, New Year.
January 1st, okay.
Yeah, New Year. We started on New Year.
2.5 months are over, and there, because the smear was negative, we don't have first line and second line LPA.
Yes, ma'am.
So have we got the culture now? Culture report?
Culture also till now not positive, ma'am. So they are waiting for further.
So it is
So
already
not positive. MTB not detected till now.
okay. So it is not detected. So if the culture is negative. Okay. And follow-up culture, now we'll be sending it 9 weeks. So 9 weeks.
Even at the end of 2 months, patient doesn't have adequate secretions also for expectoration also. So anyway, we try to induce and we given the samples. So smear came as negative. So we are again waiting for MGT, second follow-up MGT.
Okay.
But there is no significant sputum productions at the end of 2 months, and the patient have 1 kg weight gain also. Otherwise, patient tolerating at that 5 days abdominal pain. After that, no other issues. Till now, patient tolerating very well.
Okay.
Dr. Rishi, you have. Oh, sorry, Dr. Alpha, have you completed?
Yeah. So about the second question, because the second patient seems to be having more extensive disease. And does the second patient not have any past history of TB?
No, ma'am.
No, ma'am.
No prior history of anti-TB drugs.
Okay. And there was a delay in diagnosing this case because he's got extensive disease.
Yes.
Okay. And here also I would be more interested in knowing whether patient is doing okay clinically, and I think it's 1st of February. So just about 6 weeks are over.
Yes. Till now, no issues, ma'am. Even though the lesion is extensive, involving both the lungs. So as per our SOP guidelines, extensive pulmonary TB is not an exclusion criteria for BPaLM. So only extensive extrapulmonary and disseminated only is an exclusion, but extensive pulmonary TB we can start BPaLM as per our SOP guidelines. So that's why we started BPaLM for this patient.
Okay.
Thank you, sir, for answering the queries. Dr. Rishi, you've raised your hand, and then DTO Hazaribagh. Dr. Rishi, you're muted.
Good audio. Yeah. Madam, this case is good, madam. First things, just because we are already not going on training to my all DTOs also. my first concern is that when we initiate the BPaL regimen, we do the culture DST, just baseline DST for beta-alanine, linezolid, and protamid. Has this been done, sir, in both the cases?
The sample given, sir, but culture found to be negative, sir, till now.
Okay. And as you already mentioned that in both the cases, there was no previous history of any kind of ATT,
Yes,
especially for beta-alanine, linezolid, and protamid. So there is
yes,
no,
sir.
no. Okay, okay.
Previous
That's all.
exposure.
Okay,
Okay.
okay. Thank you.
DT Hazaribagh, sir.
Sir, please show the X-ray of second patient. Madam, my name is Mohammad Shafin Rehan, and I'm asking this question on the behalf of Hazaribagh. Madam, sir is requesting to show the X-ray of second patient. Can you show it to us? Yeah. Thank you, madam. There is a very extensive lesion on the left side, and also cavitary lesion, bilateral cavitary lesion is there.
Yes, sir.
Can it be treated by BPaL regimen?
Yes, sir. Please.
Can it be treated with BPaL regimen?
Yes, sir. That's why just to answer, sir. Extensive pulmonary TB is not an exclusion criteria for BPaLM cases. So we can initiate BPaLM for extensive pulmonary TB. If it is extensive extrapulmonary like CNS TB, miliary, or disseminated, or a spinal TB only, are excluded from BPaLM.
Thank you, sir. Thank you, sir.
Yeah, good. What was the bacterial load in the CBNet? There's a question in the chat box. In the first case, when we initiate the treatment on the basis of CBNet report, what was the load, bacterial load be?
First case, it is medium.
It's medium.
Medium.
Have we culture of the first case, second case, culture, AB culture?
Please show the slides. Second case. MTF culture MTB detected, which shows resistance to pyrazine.
Yes. Yes.
Moxiflux and linezolid sensitive.
Yes.
Thank you, sir. So, Dr. Alpa, we'd like to have your comments on both the cases, case 1 and case 2.
Okay. So, case 1, it's rightfully said the patient has got limited disease, and young 65-year-old male, limited disease with typical symptoms. And here we have only RIF resistance, which is there, and we don't have the report for LPA, and the immediate culture is so far negative. So this patient does fit into the criteria, and I think rightfully BPaL regimen has been started, and it's almost I think 2.5 months, and this patient is doing well. So I think nothing really to add in this case. The patient is fitting in well with the BPaL regimen criteria, and he should do well. Only thing, one comment would be that patient, since he is an alcoholic, and what is the BMI of this patient?
And we have not exactly, I don't remember, but he is moderately built man, nor undernourished or low body weight.
Yeah, but only issue would be because he's an alcoholic for more than 20 years now, we need to watch out for peripheral neuropathy. Because patients who have low BMI, alcoholic, diabetic, they are more prone to develop peripheral neuropathy. And since we already passed 9 weeks, so I think now if he develops peripheral neuropathy, we may still be able to continue with the regimen. But we have to screen this patient on every visit about neuropathy symptoms. So that is one suggestion from my side. And
sure.
Yes. About the second case. And now this patient, he does have a very extensive disease. So of course, our BPaL regimen guidelines, the extensive pulmonary disease is not one of the exclusion criteria. So rightfully, you have started this patient on BPaL regimen. That's fine. My only concern would be that patients who got extensive cavitary disease, even in the past, we have seen with all other regimen that these patients are, likely to relapse. So many of our patients with all or longer regimen who have completed their treatment and have been compliant, or even in salvage regimen, this is an issue we have seen that the relapse rate or failure rate is higher. But I think our own Indian studies, as I know, have done well with this kind of extensive disease also. The only concern would be whether in these patients 6 months of treatment would be good enough, or we need to extend for 9 months. Even in our DSTB patients or in our other patients with cavitary disease, we tend to give little longer. Though I know that there is no evidence to suggest, or we haven't really studied that these patients with extensive disease would do better with 9 months of treatment. But I would suggest, I think in this case, probably giving a longer duration of treatment would be better. And I would also like to know Dr. Singla's view on this aspect. So this is one comment about this patient. Again, I think this patient also, one has to watch out for peripheral neuropathy and development of ADR, because that's one of the factor which which impacts the outcome of the disease. He's also an alcoholic, so we need to watch out for that. His hemoglobin is already on the level lower side. That could be because of his extensive disease. And again, one other concern which I have is that we have not been doing in DST for this patient. So far, guidelines have said that even the patient is not exposed, we can do without bedaquiline or pretominide DST. But we've already started seeing, primary, like many of your, few of your cases are primary drug resistant. So we have started already seeing patients with primary bedaquiline resistance also. So I think bedaquiline sensitivity we should be having it part of the program now. Again, I would like to have Dr. Singla's comment on this aspect also. So this is what I have to share about the first two cases.
Thank you, Dr. Alpa, for your comments. You see, taking one by one, first is this case as bilateral extensive disease. Left lung is practically the whole lung is involved. Even the right side, there is upper lobe, there is a cavity with the lower. Can you show the other slide? Case 2.
Case 2, yeah.
So in that case, one thing we must remember is that today, as per the current national guidelines, if somebody is less than 14 years of age, we cannot give BPaLM. Only two choice. First, consider shorter regimen. If it cannot be given due to any contraindication, we think of longer oral regimen. In more than 14 years or more, like this case was, first preference is the BPaLM. In case BPaLM cannot be given, there is some contraindication, we think of shorter oral 9 to 11 months of regimen. If even that cannot be given, we think of longer oral regimen. In this case, because of the bilateral extensive disease, otherwise patient is eligible for BPaLM. Suppose there was some other criteria for not enrolling him, then in this case, shorter regimen should not be considered, because bilateral extensive disease is a contraindication to give the shorter regimen. And we have seen in the field conditions, many times this X-ray shadows or the X-ray interpretation is missed. And even patients who have the bilateral extensive disease, they are put on shorter regimen and they may not respond well. Number two, as per Dr. Alpa's comments that since it is a bilateral extensive disease, we should consider instead of 6 months, 9 months. You see, as a physician, we all have this apprehension in mind that if I give for 6 months, will patient relapse or not? So I think number one, the message should be clear through this forum that as of today, as per our national guidelines, irrespective of the extensiveness of the disease, we have to give 6 months. Of course, we have to follow the patient after 2 months. Every month, we need to do this smear and culture. In case we find clinically patient is not responding, radiologically patient is not responding, rectologically patient is not achieving sputum conversion, that means he's heading towards failure. So in these cases, of course, we will take a call, but extension will not be considered as of today. The only criteria, the few criteria for extension of treatment from 6 months to 9 months are, like number one, the linezolid cannot be given 600 milligram daily after 9 weeks. If after 9 weeks you feel due to some reason we have to reduce the dose of linezolid to 300, like adverse drug reaction, peripheral neuropathy, or anemia, or something else, and we can continue only with 300 milligram. In that case, we have to extend the duration from 6 months to 9 months. Number two, the criteria for extending is that if there is an intolerance to moxifloxacin and we have to stop it, again we will extend the duration from 6 months to 9 months. You see, we need to remember is if in case we have to stop any of the key drugs, that is bedaquiline, pitromanid, or linezolid, due to any reason, in that case, patient has to be declared as failure, and we have to think of the alternative regimen, that is modified longer oral regimen. So that has to be. Number three, coming to the bedaquiline resistance. This is a point of debate. As of today, it is believed in our country for patients who have not been exposed to bedaquiline in the past, who have never taken bedaquiline in the past, the expected incidence of resistance to bedaquiline is low. However, in cases who have been exposed to bedaquiline in the form of shorter regimen or longer regimen, and they have not shown good response or have failed, in these cases, the chances of bedaquiline resistance are definitely high. There are some reports from a few centers. There's like 10%, 15%. We are a little higher, maybe because of the tertiary bias. But in these cases, one must keep in mind who have taken bedaquiline for more than 1 month and have not shown good response. In this population, there are chances of bedaquiline resistance, and that is why in our national guidelines, anybody who has taken bedaquiline more than 1 month and now reports to us, and we do not have bedaquiline sensitivity with us today. So in these cases, we will be denying, will not be giving bedaquiline to the patient. And here comes the role of TNGS. Our DDG, Dr. Urvashi, is already decided, and she is going ahead with it, that in these cases, in all these cases what being put on BPaLM, we should have the benefit of TNGS, targeted NGS, which can give results in say 3, 4, 5 days within a week in sputum positive cases. And then that can guide us that even if patient has taken bedaquiline for more than 1 month, whether we can give BPaLM or not. Because in absence of TNGS, 90% of the patients who do not have bedaquiline resistance but have taken it for more than 1 month, they will be denied the benefit of this 6 months of treatment. So it is, again, it seems very, very essential for our program that we have in these cases upfront TNGS, which can give us the resistance to the newer drugs, and we can decide accordingly. So that's what I want to say about this case. Thank you. Dr. Urvashi, ma'am, you are there, so we would like to have your opinion on this aspect specifically.
Yeah, ma'am has joined now. So thank you, ma'am, for joining us.
Good afternoon, all. Thank you for all the efforts that you all make for Dr. Singla, sir, Dr. Neeta Singla, Dr. Manpreet, NTF chair, and all the esteemed experts, Dr. Ramesh, Dr. Rishi, Dr. Alpa, of course. So let me allude to the countrywide data on BDQ resistance, because that's one question that came up, is not very high. Dr. Alpa, I'm not sure about Mumbai. Mumbai per se may be having a higher, again, there is no documentation. So I would appreciate if, unless there is a study which talks about it, let me tell you the countrywide, it's less than 1.15%. Okay, maybe 1.15%, as was found in the ICMR BPaL study, the NIRT data, which I would say should not really keep us from using the BPaLM regimen. And unless in Mumbai you can you have a published work or a documented higher resistance, we look forward to such a publication. Also, it could be lineages or geographical predilections. So those questions need to be answered. Now, regarding the samples would have been sent to NIRT, if I'm not wrong, Dr. Ramesh. The cultures have been sent to NIRT Chennai.
Yes, ma'am. Yes, ma'am.
So NIRT Chennai is a supranational lab, and it's the pride of the country. Like NITRD, it is one of our NRLs. We actually take pride in. So I am sure they must have. Somebody is asking what protocol was used during culture. The best protocol must have been used. I have no doubts. And culture is under incubation, not yet negative. Having said that, I will also like to add, when we rolled out the BPaLM regimen, we rolled out 3 things with it. One, we trained 25 labs to do culture DST. 2, bedaquiline, pretomanid, linezolid, moxie, in addition to the other second-line drugs they were doing, which is being followed at 5 centers of excellence and the NRL supporting them. NIRT is one of them. In fact, NIRT was instrumental in training the 25 labs across country who have got the training in bedaquiline and pretomanid, and they're already doing the work. So I think once the culture grows, the phenotypic DST will come through. The culture in one patient had grown, so I'm sure the phenotypic DST will come through soon. Talking about TNGS, again, TNGS is being done for BPaLM patients at these 5 centers of excellence. Since we just launched it, there are initial few teething issues. Here again, for TNGS, 15 labs are going to be immediately trained, and so the 5 centers of excellence are already equipped, trained, and they have started the work. The other labs will also get trained soon. And these are the 2 things that we've already rolled out. We also intend to roll out PKPD for all the BPaLM patients, which again, initial teething troubles, teething issues, we're sorting them out. So with all this, we'll have a composite answers to any failure, if at all, that develops later while during treatment, the patient doesn't respond or something. We will have answers because the baseline culture, there is more likelihood to grow than the follow-up cultures. Follow-up cultures are also being done. The 4th thing we have introduced with the BPaLM regimen is the FDA staining for all these samples during follow-up, so that we can differentiate whether there are any live bacilli or there are only dead bacilli, so that at least we know the response to treatment. Again, for this, NIRT Chennai was instrumental in training 25 labs across the country, and the program guidelines say that this follow-up with FDA staining, with culture, has to be done throughout the treatment and at the end of the treatment. So much so about the program guidelines and how we planned it. Of course, if there are more questions, and of course, I'm sure with Dr. Singla sir, Dr. Alpa, and the other experts in the group today, any other questions will also be addressed. You are all aware why we added moxifloxacin despite FQ resistance is the evidence globally where we found adding moxi to FQ resistant patients as well ensures recurrence-free cure. So the science behind it is very strong, and that is the call the country took. Thanks to all the experts who were on board, Dr. Singla being one of the lead experts. We have made a regimen which is strong, and we hope to be able to give better treatment success rates to our patients, better than what we were achieving earlier. Fewer recurrences, if at all, and we are all set towards this. Any more questions we can take now or later as they come? Thank you.
Thank you so much, ma'am. We have 2 more queries for these 2 questions.
Yeah. So one question is that we have started BPaLM at more than 14 years of old. But what if the weight of the patient is less than 30 kg? Shall we continue with the BPaLM in a patient with more than 4? Sir, can you take this answer question?
Okay, Dr. Alpa.
Ma'am, can you take this question? Patient, an adult patient weighing less than 30 kg. Can we start BPaLM in such kind of a patient also?
That is not one of the contraindication to start. And I don't think in the new guideline they have specifically defined the linezolid dose, but less than 30 kg, I think the linezolid dose would have to be lesser. I'm not very sure, and I would like Dr. Singla's opinion, because in the guidelines it is not specifically mentioned that linezolid dose in a patient with less than 30 kg, what should we be giving?
Yes, Dr. Alba, I agree with you. So these cases are sort of, there are, you can say, some gray area. But one thing is clear in the guideline that the dosages mentioned in the BPaLM regimen will remain same irrespective of the weight band. Whether low or high, they will remain same. Of course, for a person who is more than 14 years of age, is very malnourished and a weight of less than 30 kg, we will have our own apprehensions whether patient will be able to tolerate or not tolerate. But by and large, the dosage will not be altered. That is something different that once you start and you start linezolid 600 and you find that patient is not tolerating. But again, as per guideline, if in the first 9 weeks, due to any reason, whether ADR or something else, patient is not able to tolerate and requires less than 600, say 300, this will be declared as failure and we'll have to look for alternative regimen. But after 9 weeks, in case somebody is not tolerating 600, but we are able to give 300 milligram, in that case, the BPaLM regimen will continue and we will extend the treatment duration from 26 weeks to 29 weeks. So that is the current guideline and the current understanding. Thank you.
Thank you, sir. And Dr. Ramesh, sir, there's a question coming repeatedly for the cause for the pain abdomen in the first patient. So was pancreatitis was ruled out, must have been ruled out by your team, and lactic acidosis. I mean, drug-induced side effect. Was it? Have you noticed drug-induced? Was it due to the drug-induced side effect, or could you able to find out any cause for the pain abdomen for which the drugs were withholded for a period of 5 days?
As per clinical evaluations, we could not find any particular drug which produced any biochemical changes, either like liver changes or raised bilirubin like that. No? And we are not measured during that pain time. We are not actually measured the pancreas level as well as lactic acid levels. So we just undergone mainly the radiological evaluations of ultrasound and CT abdomen. And regarding the biochemical evaluations, we have done routine blood counts along with the LFT and the urine routine. So these found to be everything comes under normal limits. So we could not pinpoint which drug has produced this abdominal pain. So even we inquired regarding the diet habits during that period. Is there any possibilities of like gastritis, any food-induced gastritis? So patient didn't give any significant history related to diet also. So we could not come to the conclusions which drugs probably produced, but we have discussions with the pre-NIRT teams. We have already engaged in the BPaL studies. So they only told pancreatitis also is the one of the reasons we can evaluate for that. But we did pancreatic enzymes only after the pain has been subsided, and we have restarted the regimens after 5 days. But after 5 days, patient is tolerated very well. So no further clinical or biochemical deterioration since then. So we could not come to the conclusions which drugs produce this, or is it a drug induced or non-drug induced. Even that conclusion also we could not arrive. But after 5 days, patient tolerated the drugs very well. This is the actual scenario, ma'am, basically.
Thank you, sir.
Thank you, sir. So we go to case number 3 now.
Yes, ma'am. 37 years male came with complaints of cough with expectoration, shortness of breath, with evening rise of temperature and loss of weight. He has a known case of diabetic and hypertensive. He was an alcoholic. We proceeded with chest X-ray and sputum reports. Next slide, please. Sputum report CBNAT was found to be MTB detected and RIF resistance. First line LPA, MTB detected, RIF resistant, INH high level resistant. Second line LPA, fluoroquinolones and second line injectable drugs were found to be sensitive. Hence, we diagnosed the patient to be primary MDR. Chest X-ray shows right upper lobe lung abscess. We proceeded the patient with the BPaLM regimen and diabetic control measures were taken. Next slide. He has no prior ADT history. He was a smoker and alcoholic. He was a known diabetic and hypertensive, which was not on regular treatment. We proceeded with pre-treatment evaluation and diabetology opinion. Cardiology was no conduction defects was found, and ECG and echo were found within normal limits. After opinion, both I fundus normal at present, and CBC, RFT, LFT were found to be within normal limits. We would like to add a next slide, please. In this patient,
Continue.
next slide, please. In this patient, initial HB was found to be 9.3 and urea creatinine was found with the normal limits. During the course of treatment, we found a fall in HB in day 3, which was found to be 8.1, and urea creatinine were found to be mildly elevated. So we continued ATT, but we have started with other measures to find the cause for anemia, whether it is drug induced or not. We proceeded in view of increased urea creatinine in thought of AKI. We treated him with IV fluids. Ultrasound abdomen showed bilateral hydroureteronephrosis, but we couldn't find the cause for bilateral HUN. No other signs of no other causes that causes anemia could be found. But we continued ATT. Serial HB monitoring showed no further fall in HB. My patient shows clinical improvement and he has no signs of renal failure. We advise the patient to continue ATT. If we advise to return if he feels any signs of renal failure, like decreased urine output, or like feeling anemia, signs of anemia, like signs of cardiac failure, or signs of giddiness. And we have followed him with repeat HB, which showed no fall in further hemoglobin. Next slide, that's all.
Okay, so any questions on case number 3?
Actually, the date has been mentioned in the slide as 1/1 is wrong, ma'am. Actually, the regimen is initiated in the February 2025 only, and the HbA1c is under the control. It is around 5.7. So this patient, actually, we started the BPaLM, but initial after 3rd day, it shows a drop in hemoglobins. But a patient didn't show any signs like fatigue or nothing like that. So anyway, there is no new onset of complaints which has been noted. So since patient as an inpatient in the tertiary centers, so we proceeded to continue BPaLM further with the monitoring. So after 3rd day, again, it shows same level, it is 8.1. And again, we repeated on the 15th day, it is 8.1. And actually, as per SOP guidelines, whenever there is a fall in hemoglobin of more than 10% from the baseline value, so we have to interfere with the stop the linezolid, then proceeds. Since this patient is in the tertiary centers and there is no fresh symptoms related to anemia and renal failures, so with we proceeded, and under strict monitoring only is there. So that is why we are able to continue the BPaLM for this patient. But anyway, after the end of 15 days, there is no further fall in hemoglobins, and patient, there is no new symptoms. Patient tolerating ATT till now, ma'am.
Yes, sir.
Do we have the culture report now? It's about 6 weeks since we started.
Still not yet received, ma'am. Both from NIRT as well as our sample not yet received, ma'am. Almost 15, 20 days only. 20 days only it takes, ma'am. 25 to sample given. So we can wait, ma'am.
Okay. And
Yeah.
any secondary bacterial infection was ruled out, because this patient being an alcoholic and diabetic, and he does have
Yes.
Have we done a bacterial culture also this patient?
We have done a bacterial culture which showed Klebsiella pneumoniae sensitive to piptas, and we have treated the patient with 14 days of piptas and metronidazole. We have found a clinical improvement in the patient.
Sir, my concern is that in such patients where hemoglobin initially was 9.3 and after day 3 it is at 8.1 and still continuing for 2 weeks at 8.1. But in field conditions, sir, what we can do, whether we have to stop linezolid, because this patient is in a tertiary care center, in a COE center, so they are monitoring it. But sir, can we continue with this linezolid in field conditions, or we can stop, sir?
So as per SOP guidelines, whenever there is a fall in hemoglobin of more than 10% from the baseline value, you consider it is more than 10% only. It's around 1.2% has been reduced. So as per SOP guidelines, we have to stop the linezolid and we can improve the hemoglobin levels, then we can restart with the full dose of 600 mg. Up to 9 weeks, we cannot reduce the dose of linezolid to 300 mg like we do in other regimens, but here we cannot reduce. So we can proceed with the 600 mg only till 9 weeks. After 1 week, if it needed, we can reduce the dose to 300 mg. And if that scenario, we can extend the duration from 6 to 9 months.
Okay.
Thank
you.
Can I say something?
Sure, Dr. Alka.
Yeah, so I think these are the guidelines is 10% drop, but I think all the guidelines say that ultimately it's the clinician's decision, which is very important. Now, in such a case, patient who is an alcoholic may have a lot of other malnutrition. The disease of anemia of chronic origin also we have to see with such extensive cavitary disease. Sometimes patients starting on AKT, their nutrition may not be proper. So I think all these factors have to be taken under consideration. And like in this patient, we've monitored it serially. So though there is from the baseline value, there was initial drop to 8.1, but later on, the drop has not been there. So even if this patient was not on tertiary center, but if adequate monitoring is done, and also sometimes the fluid imbalance and dilutional effect, all those factors also tend to reduce the hemoglobin. So we have to consider all these factors and then take a decision about stopping or reducing linezolid, because within 9 weeks, if you do, that means that you have to put the patient on alternative regimen. So I think the 10% mark, it should not be like a complete cutoff mark. You take it in the entire clinical perspective and then take a call on this.
Yes, Dr. Alpa, thank you very much for your comments. You see, in this case, as I have a little slightly different opinion in the sense that yes, patient is diabetic. He is likely to have anemia of chronic disorders also, besides having iron deficiency anemia. So first of all, when we are starting the treatment and we find the hemoglobin is 9.3, we must do the peripheral smear for type of cells. We should do the iron studies and document and study whether patient is having anemia due to what cause. Is it anemia of chronic disorders, iron deficiency anemia, or nutritional anemia that is not taking well, number one. Secondly, once we start with the 9.3 grams, and on day 3 we find it has gone down to 8.1, whether 10% or 15, whatever it is. But there is a significant fall. And not only that, now the level is 8.1. Anything less than 8 grams, we are not comfortable in continuing with linezolid. This patient had the luxury to be in a tertiary referral center, being managed by senior physician. So patient was admitted. So in that case, as explained by Dr. Ramesh also. But in the field condition with Rishi is asking, whenever you have this scenario, we should stop linezolid, assess the level of hemoglobin and these tests like peripheral smear, etc. And the build up the hemoglobin by giving blood transfusion.
Can you mute?
Build up the hemoglobin by giving blood transfusion. And once the hemoglobin has increased, we should start by giving 300 milligram of linezolid and rapidly try to build up to 600. As Dr. Ramesh also said and Dr. Alpa also said, that in the first 9 weeks, if you are not able to give 600 milligram, in that case, we'll have to declare the patient as failed, and we have to go for the modified or longer regimen. So in these cases, initially we stop, build up by giving blood transfusion, evaluate what type of anemia it is, then start with 300, and then try to go for 600. That should be the dictum in managing such cases. Of course, if it is after 9 weeks, then the things are different. Again, the same approach will be there. Only thing is, after 9 weeks, in case we are not able to add the dose of 600 milligram to the patient, we may continue with 300, but the duration of the regimen will be increased from 26 weeks to 39 weeks. So these first 9 weeks are very crucial before we deny the patient of this good regimen of 6 months. So that we should try our best that we are able to build up the hemoglobin and we are able to at the same time continue with 600 milligrams. Thank you.
Right. So are there any questions? There is one question. What was done about the lung abscess? Any surgical consultation for lung abscess management?
Actually,
Do we have, after treating the patient with piperacillin and tazobactam, do we have another X-ray done after the course of pip-taz?
We have, but we have not put in the.
So did it show improvement?
Yeah, sorry for that, ma'am. But the fluid level has not much changed significantly, ma'am. Actually, repeat X-ray also. But sputum production as such has been reduced and purulency has been changed, but the cavity level has not been much changed, ma'am, basically.
Okay.
you see, in this case, as the question is being asked in the lung abscess surgery, whenever we have lung abscess, first of all, we need to identify the causative organism. In this case, of course, we have documented that it is tuberculosis. Add on to that, it is very common to have mixed infections like tuberculosis plus pyogenic infections or fungal infections in these kind of activities. Surgery should only be considered when patient is not responding to your medical therapy by antibiotics or by giving anti-TB medication. Only in those cases we should think of surgery. I think we need to give time to the patient, how the patient is improving, and then only we need to take that call. Secondly, in this case, if you see, practically the right entire lung is involved. Not only the upper lobe, middle lobe, lower lobe also, and even the left lung, I find there are shadows. If you do the CT scan, we may find that even the left lung is also not normal. So the option of surgery in this case will be very, very limited. So first we give good anti-TB medication, good antibiotics, and then reevaluate and think of surgery. That's what I feel.
Yes, sir, he is having some lesions on the left also, sir, in the CT chest. Yes.
Yes, Dr. Shakil, over to you.
Yes, thank you very much. The lung abscess has raised the questions to me that whether there is a mixed infection. So there was some other infection probably that has been probably addressed in this case. And I would request the presenters to present those three scenarios, those managements as well, because that will help us to understand that we are not only dealing with a lung abscess of TB origin only or other origins. That was my actual query. And when the follow-up X-rays shown no change in the cavity, and how long it was treated so far?
So he has been antibiotics for more than 2 weeks, sir.
So 2 weeks, it's okay.
But how long, culture sensitivity when we initiated drugs, sir. Culture post. Yes, sir, please.
How long is the treatment for the BPaL regimen?
6 months, 26 weeks.
So after 26 weeks, what is the X-ray findings? Again, we need to know.
So the patient is on BPaLM for since 27 Feb 2025, sir. On admission, the patient presented with lung abscess. We have proceeded with culture sensitivity, which showed Klebsiella pneumonia, which is sensitive to pip-taz. We treated with pip-taz and metronidazole. After 14 days of antibiotic, we take a repeat X-ray, which showed no significant clinical or radiological improvement, but patient improved clinically. So we have discharged the patient on BPaLM. We have kept it under follow-up, sir.
Okay, thank you very much. That's the thing I wanted to know, that there was some other things for which you treated with this. Yeah. Thank you. Thank you very much.
Yeah. So, sir, we go to patient number 4 now.
Yes, sir. 54 years male who presented as complaint complaints of cough with expectoration for 2 months, complaints of temperature and loss of food, chest X-rays. And can we move to the next slide? As sputum reports showed CBNAT MTP detected resistant. First line LPA rifampicin status is inferred and INS low level resistant. Second line LPA fluoroquinolones and second line drugs will be found to be sensitive. Chest X-ray, next slide. In chest X-ray, we could find dextrocardia with situs inversus and bilateral extensive cavitatory lesions. We proceeded with patient on BPaLM. He has no, next slide, please.
Next slide.
He has no comorbidities. He has a history of drug sensitive TB in 2018. which was defaulted in 2 months. He was a smoker and alcoholic for 20 years. We proceeded with pre-treatment evaluation. Cardiac and after were found to be normal limits. Pre-treatment HB was 11.4 and platelet was 3.33 lakhs, which was also found to be normal. And since patient was started on bedaquiline containing BPaL regimen, patient has encountered no. Next slide, please. Patient encountered no adverse events. Serial QTCs were found to be within normal limits, and no further fall in hemoglobin and platelet was noted. No ADR was encountered in this patient.
This is a case of a drug-sensitive TB who has been treated a few years back and taken for just 2 months and lost follow-up. Now again presented with the chest symptoms and found to be MDR TB and be initiated on a BPaLM regimen. So almost he is on 3rd week. So till now there is no complaints. So 15th day CBC and liver and renal functions are found to be within normal limits. And actually SAR requested regarding the ECG. So since patient has been discharged, we could not, since patient doesn't have that smartphone to send the ECG, so we could not put a ECG. So since it's a case of dextrocardia, ECG also is valuable, but sorry for that.
So have you gone to culture in this patient?
So culture awaited, ma'am. So culture given at NIRT, results are awaited, ma'am.
Okay. Because he is a patient and who has been alcoholic, who is defaulted once on drug-sensitive TB. And I don't know whether the history can be completely reliable and he's taken any other second-line AKT also. I think that we have to really be very careful. And these are the patients, I think, where probably getting a bedaquiline sensitivity would be more important in this particular case.
So since he is already defaulted only, we have given extensive counseling for these patients, man, because the defaulter, we always will have a habitual tendency to default against. So we have multiple sessions of counseling for this patient as well as his attenders. So after even explaining the regimens and the durations and the side effects, so after repeated counseling only, if you are adherent to the drugs, then only we can initiate the regimen. So he has accepted and is even understood the scenarios very well. So then only we have started, because since alcoholic and defaulter, we are initially we refused these type of patients in the January month. So when the initially we given permission to initiate BPaLM, the first 1 month we refuse all defaulters and all these patients because they have tendency to default again. So and this is the first defaulter patient we initiated. So but after repeated counseling only we initiated the regimens. We hope the patient will continue the regimen.
Yeah, so I think that's very important, because yours being your tertiary center and you have all the support available. But these are the patients, he has, multiple things which can go against his favor and for favorable outcome. So one is that he's got extensive disease, he's got bilateral disease, extensive lung damage. He's defaulted in the past, also the chances of default would be higher in this patient. He's been an alcoholic and smoker. So all those factors, and these are also patients who are more likely to develop ADR, whereby you may not give the complete regimen. So one has to have a much closer follow-up for these patients and be very, very aware of these factors which may lead to failure. And very extensive drug history, maybe looking at the papers also would be very important, whether he's already been exposed to any of the drugs of BPaL regimen. So these are very important things to be considered in this patient.
And all our BPaLM patients who has been discharged after the from our center, ma'am. So concerned DTOs, concerned district TP officers have been contacted, and they have been allotting one caregiver for each patient to follow the adherence regarding the drugs. Now, even if they missed any particular drugs, even the first patient also like that only they came to our notice that the patient has abdominal pain, and then only they referred here to further. So all patients have been strictly monitored by the consented DTOs.
That's excellent.
Thank you, Dr. Ramesh. You see, I fully endorse the apprehension raised by Dr. Alpa. You see, these are the cases patient consumes alcohol for so many years. Patient has lost to follow up earlier. We are not very sure whether what was given after that and whether he or she received any regimen with or without bedaquiline and all this. So in these cases, even in the field conditions, which will be a challenge, the referring medical officers or the DTOs should be in touch with the laboratory that I had sent this sputum sample and what is the midget report. Because otherwise, we tend to miss it. And case culture is positive. We also need to follow with the resistance to the neo drugs, like especially like bedaquiline and linezolid in these cases. Because in case they have that, and we are continuing with BPaLM, this will not be good in the interest of the patient as well as in the interest of public also, because then patient may become resistant to the drugs and spread the same to the other. Number two interesting thing I find is, as already told by Dr. Ramesh, this is a case of situs inversa. You can see the dextrocardia, you can see the gastric bubble is on the right side. And in these cases, sometimes because of the dextrocardia, which may not be known to the physician treating, he or she may feel that this is extensive damage to the right lower lung, although the shadows may be because of the heart being on the right side. In this case, of course, the lung is definitely involved, but sometimes, even if minimal involvement, it may appear that patient has got the significant extensive involvement of the right lower lobe also. So that we also have to keep in mind. Can you go back the previous slide? Number three is this is just like that. This report of first line LPA rifampicin inferred. You see, I think I stand corrected that in our guidelines, when the laboratory is releasing the report, they do not mention whether inferred or not. They just mention rifampicin resistance, INHA or CAT-G, because clinicians, every clinician may not be knowing what is the significance or interpretation of inferred. So I think the general, the understanding to the laboratory is they just say rifampicin resistance and not about this inferred, etc. That's what I feel. Dr. Urvashi is there or Dr. Manpreet Bhalla, they can throw light on this comment, please. Thank you.
Yes, Dr. Shakir, you have a question?
Yeah, as the patient is having dextrocardia, clearly dextrocardia, so in these types of patient, bronchiectasis and other things should be evaluated through CT scan or other things, because that can coexist with these patients. So had that been done, or for these types of patients, TB can be associated with bronchiectasis, and treatment of extensive airway clearance along with other medications for bronchiectasis should be prescribed. Otherwise, we cannot have the good result only by TB treatment. Thank you very much.
Okay, thank you for that point, sir. Actually, the patient doesn't give any proper history like that, repeated expectorations or significant sputum productions. And anyway, we will look into that also when it comes to the next visit, sir.
Right, sir. Dr. Alpa, can we go to the next case now?
Yes.
Yeah. So case number 5.
This was the first patient where we initiated a BPaLM regimen. This patient presented as complaints of cough with expectoration and evening rise in temperature and loss of weight for the past 2 months. We proceeded with sputum analysis and chest X-ray. Next slide. Sputum analysis showed CB-NAT MTB detected RIF resistance and first line LPA RIF resistance and INH both high level and low level resistant. Second line LPA fluoroquinolones resistant. We have done a midget culture which showed pyrazinamide resistant and moxifloxacin linezolid sensitive for this patient. This patient has a prior history of 2 spells of drug sensitive TB, which she lost to, next slide please, which she lost to follow up in 2017 and 2022. Previous slide please. Chest X-ray showed left tracheal shift with left lung volume loss, both upper and lower mediastinal, right upper lobe fibrosis, and left upper zone mid zone heterogeneous opacity with evidence of whole heel lesions. And we started the patient on bedaquiline containing BPaLM regimen. Before pre-treatment evaluation was found to be cardiology, and after was found to be within normal limits. Pre-treatment HB was found to be 12.5 and platelet was 3.71 lakhs, which was also within normal limits. Patient was observed for the 14 days. CL QTCs were done, which was found to be in the normal limits. And all the HB and platelet was also found to be in the normal limits. Patient encountered no adverse reactions. The patient was discharged.
This is the first female patient we initiated BPaLM regimen. And since previous 2 spells of anti-TB drugs, because of feeling well, she has been discontinued. There is no ADR has been documented in the previous. So since she becomes symptomatically improved, she just stopped the regimens. So anyway, again, we have given extensive counseling regarding the importance of TB and her lung status as well, and regarding the continuation of TB treatment for her as well as for the benefit of her families. So since she developed MDR-TB, the counseling is given for the family members also. So with that, we initiated regimens. Almost 1 month is over, and patient till now there is no issues, and patient symptomatically better and no complaints, and adherence also till now is good.
So I think from treatment point of view, I don't have much to add. But this and the previous cases and all, just one fact I would like to point out that most of these cases, out of 5 cases presented so far, 4 cases have had extensive lung involvement. So one after treatment, and all of them have been, I think, alcohol in there. Some of them are smokers also. So once the treatment is over, these are the patients who should be closely monitored for relapse, because with all these factors, rate of relapse would need to be corrected. Secondly, most of these patients are going to have a lot of post-TB sequelae. So secondary infection and post-TB OAD. So TOPD is also going to be very common in these patients. So I think from that point of view, also once the treatment is over, they need to be evaluated, and some form of rehabilitation have to be given. So de-addiction, rehabilitation, nutrition, following up them regularly to detect relapse would be very important in these cases.
Yes,
Yeah.
I agree with Dr. Alpha. You see, sometimes we focus only on the chemotherapy, but this de-addiction part, the nutritional support to the patient, and after that, the post-TB lung managing, requiring bronchodilators, etc., and maybe the physiotherapy, the rehabilitation programs, enrolling them into this. So these things are equally important because they will have these symptoms maybe rest of the life. So, and once pathologically they are negative, they are cured, they will need all these things. And we need to consider, specifically in these cases, all these measurements to be offered to the patient. Thank you. We can go to the next case.
Yes, sir. One thing in this case, sir, had this lady been age of 27 years, and if she would want to bear a child, so in that case, sir, we have to ask the questions also regarding lady. Though this case, this lady is of 37 years, and I hope her family is complete. But when such cases come, when the age is less than 27 years, say 10 years behind, back. So in that case also we have to ask about the pregnancy, will she continue or not, and in that case, sir, we have to change the regimen also, sir. This was my concern, sir. Thank you.
Right. So we go to next case, case number 6.
This case we'd like to present because it's a patient of retroviral disease who was started on BPaLM. The patient presented with complaints of cough with expectation for 3 months and fever with evening rising temperature for 1 month and significant loss of weight. We proceeded with sputum analysis and chest X-ray. CBNAT showed MTB detected RIF resistance, and first line LPA RIF resistant, INH high level resistant, second line LPA fluoroquinolone resistant. This is considered the patient to be pre-XDR TB. She has a history of previous drug sensitive TB in 2023, lost to follow. He was a smoker and alcoholic. He was a known case of retroviral disease for the past 15 years on ritonavir, dolutegravir, and darunavir. His pre-treatment evaluation was found to be within normal limits. We started the patient on BPaLM. The patient tolerated ATTs. BPaLM regimen was started on 8 February 2025. Follow-up serial QTCs and baselines were investigation like CBC, HB 10.1 platelet for 4 lakhs. They are found to be within normal limits. No adverse reaction encountered. We would like to discuss this case because the patient of retroviral disease was on ritonavir, dolutegravir, and Orna.
Since this is the who is on a third line antiretroviral therapy, and he has been treated previously with a drug sensitive TB and defaulted. So we initiated the BPaLM regimen for these patients with to continue the existing retroviral drugs. And since now there is no issues regarding the ADR aspects, and adherence also now it is good. So almost patient taken more than 1 month, but the culture report is awaited. So anyway, we get a first line and second line reports. Is found to be a pre-XDR, both INH, rifampicin, and the FQ resistance. But this...
Right. So any comments from Dr. Alpha or Dr. Singla?
I think one thing is that ADR monitoring would be more important because LFT, especially LFT and QTC monitoring would be more important when you are giving with ART in bedaquiline and pretominide in these patients. So I think that is the only thing I would have to add. I don't treat patients with ART, so I don't have a lot of experience in that.
You see, thanks, Dr. Alpha. In this case, ritonavir definitely is inhibitor of the enzyme, so it can lead to increased levels of bedaquiline. So that is what, whenever we have a regimen containing ritonavir and also having bedaquiline, so this interaction of the ritonavir increasing the blood levels of BDQ, leading to increase in the QTC interval, we'll have to keep in mind. The dolutegravir, by and large, does not have any significant interaction with the anti-TB medications, including bedaquiline. So I think better is to consult the people who are managing the antiretroviral disease in this case. He's already on the third line drugs, so they will have to choose what is the best for this patient. In case they want to retain ritonavir, in that case, we'll have to have more stringent follow-up of the ECGs and QTC intervals. Normally we do baseline, then 15 days, 1 month, and then monthly. But I think in this case, we may do every 2 weeks just to be on, just to take precautions. That is my suggestion. It can be considered. Thank you.
Okay, sir. Thank you. Okay.
Thank you, sir. We go to the next case.
All these first 6 cases, we're dealing with the BPaLM cases.
Continue.
First 6 cases, we'll be dealing with the patients who have started on BPaLM and where all we should be intervene. Next 2 cases we have put to impress upon whether we should start, where all we should not start BPaLM. The first case is MDR-TB. Is a case of MDR-TB lost to follow-up, presented with complaints of cough with expectoration, shortness of breath, and fever with evening rise in temperature. Next slide, please. Next slide. He was initially started on bedaquiline containing shorter BDQ regimen in 2024.
Next slide.
Next slide. Next slide. He has multiple spells of DSTB in 2022 and 23. He has a case of MDR-TB lost to follow-up in 2024. He was started on shorter BDQ. He was lost to follow-up in 2 months, and he is now presented to us complaints with the constitutional symptoms and cough with expectoration. Sputum reports, previous slides, please.
Previous. Yes.
Now his sputum reports were found to be CBNAT, MTB detector, rifampicin resistance, first line LPA, INF sensitive, rifampicin resistance, second line LPA, fluoroquinolones, and second line injectable drug sensitive. In his MIGIC culture, he has showed resistance to pyrazinamide and bedaquiline. Hence, he has been branded as MDR-TB lost to follow-up. MDR-TB, now he has an MDR-TB with bedaquiline resistant tuberculosis. Hence, he has started on, since he has already a prior history of exposure to bedaquiline for more than 1 month. Chest X-ray shows bilateral diffuse infiltrates with the left upper lobe fibrocavity.
Next slide.
Next slide. Since he has an already exposure to bedaquiline for more than 1 month,
Next slide.
we have started on modified all-oral regimen, which contains the next slide. Delaminate, clofazimine, cycloserine, linezolid, and levofloxacin. He has monitored with serial QTCs and baseline investigation. He has so far not encountered any adverse reaction. We are continuing his on modified all oral. We have given his counseling to continue this regimen for the 18 months. Since he has already multiple cells of defaulter of ATT.
So this is the case of MDR TB who has been previously exposed to bedaquiline in the shorter oral BDQ regimens. And the culture sensitivity also shows the resistance to BDQ. So we initiated on the modified all oral longer regimens. Since the BDQ resistance has been there, as per our replacement schedule, we initiated delaminate in place of bedaquiline. So with the other first line drugs, group 1 drugs like levoflox and linezolid, and group 2 drugs, cycloserine and the clofazimine. So regarding the BDQ exposures, if patient have any exposure to bedaquiline or linezolid in the past, if the DST pattern shows sensitivity, then only we can initiate on the BPaLM regimen. If the DST is not available or DST shows resistance and patient exposed to that BDQ or linezolid for more than 1 month, it is one of the exclusion criteria for the BPaLM regimen. This is for commencement.
Yes.
Dr. Alpa, over to you.
So, as I see in this patient, he's had multiple episodes of TB, multiple defaults. Here again, you can see extensive lung damage. His lung is pretty involved with cavitation and post-TB fibrosis. And the sensitivity pattern is really interesting. I suppose this is done at NIT Chennai. This
Yes, ma'am.
Yeah.
Results from NIT Chennai.
Yeah, so little surprising that patient had multiple, treatment of drug sensitive TB and shorter regimen also, but INS seems sensitive still. FQ sensitive. It is only that he has only bedaquiline resistant, but less of rest of the drug which he is exposed to have been sensitive. That's little surprising, this DST report to me. But anyway, even if you believe this DST report, the current regimen that we have started is delaminate, which we have proven sensitivity to, linezolid, which is also proven sensitive, and levofloxacin is also proven sensitive. We do not have information about clofa. So I think if MEGIT has come positive, we definitely need information about clofa sensitivity. Cycloserine anyway, we cannot do it. So in current regimen, we have 3 drugs with proven sensitivity. Even out of that, linezolid and levofloxacin has been exposed before. I don't know whether in the previous shorter regimen, did the patient receive linezolid or it was not.
Without linezolid, ma'am. Previously, it is ethionomide only.
So we have 2 drugs, DLM and linezolid, which patient is never exposed to and yet showing sensitivity. We have levofloxacin, which patient was exposed to but showing sensitivity, and clofa and cycloserine we do not know. Cycloserine, of course, because patient probably is not taken in the past because that's not part of the shorter regimen. So, but we still don't know the sensitivity for clofa, and levoflox patient has already been exposed to. So I think here I would probably like to have one more drug, maybe an aminoglycoside would be worthwhile. Or if we isoniazide, again, patient has been multiple time exposed to, so I won't be very comfortable adding isoniazide. But till the time at least we get clofa sensitivity, and this patient again, because of extensive cavitatory disease, I would add probably aminoglycoside till we have clofa sensitivity. Let's say clofa shows sensitivity, then at least we have 4 drugs. which with the proven sensitivity, and 5 drugs and cycloserine because it is not patient is not exposed to. So that is what I would do in this case. And again, all those other measures, so counseling and close monitoring for ADRs and is very important.
Sir, Rupak sir, since we initiated the regimen on 5-3, just almost 5 days only, or 10 days only over. So, justifiable to start amikacin at this stage, sir. Almost 2 days is over.
Yes, thank you, Dr. Mesh. You see, I tend to agree with Dr. Alpa regarding there are 2-3 reasons. One is that patient has taken 2 months of shorter regimen, and where patient was exposed to bedaquiline as well as to clofazimine and other drugs, as we know, cyclosin is not a part of it. And now we find from a national reference lab, the bedaquiline resistance is reported. Surprisingly, the quinolones are sensitive. So while we are making a regimen from group A in this case, we have linezolid and levofloxacin. From group B, we have taken clofazimine cycloserine, and from group C, we have taken delamanid. Whenever we have bedaquiline resistance, you see the chance, especially in a case who has taken clofazimine earlier, we should keep the probability of clofazimine resistance also in mind, unless the laboratory tells us that no clofazimine is sensitive. So of course we will be using clofazimine in this case, but adding one more drug from group C is desirable. Now the question comes, delamanid we have already taken from group C. Next choice is amikacin. The injectables patient is sensitive, we have the evidence. But you see, giving injections to a patient where we already have 4 definite drugs and 1 plus minus drug is a call which we have to take. Third will be pyrazinamide, but pyrazinamide is in this case resistance or sensitive. Can I have a look?
Resistance.
Pyrazinamide resistance.
So pyrazinamide is out, and then lower down will be thionamide and other things. So if I am the treating physician, I would like to add amikacin till we have the clofazimine DST pattern available. In case it is available and it is sensitive, I would like to drop amikacin and continue with these 5 drugs. Thank you.
Okay.
Thank you.
Thank you, sir. So, are there any questions? So, do we go to the next case? Dr. Alpa, can we go to the next case?
Yes, yes.
Yeah. So, we come to the last case, patient number 8.
So 49 years old male, he presented at OPD with complaints of dry cough, loss of appetite, and loss of weight. Complaints of left-sided cervical swelling, which was gradually increasing in size, painful, no purulent discharge noted. Next slide, please. He's a known diabetic and CAD. Recently, he was undergone PTCA 6 months back. He was an occasional alcoholic. Next slide, please. We have proceeded to evaluate for the lung lesions, but the parenchyma looks normal. We have encountered only a pretracheal node, which was 3 cross 4 centimeter in size. We didn't do B-bus. We proceeded with the pus or CBNAT. Microbiology reports, please.
Back slides, back. Previous. Yes, thank you.
Pus CBNAT showed MTB detected and RIF resistance, and we have sent the sample for LP and midget culture, which was ongoing. We have started the patient on all oral regimen since he is a case of disseminated tuberculosis, which comes under the exclusion criteria for BPaLM. We have started on the bedaquiline, levoflox, linezolid, clofazimine, and cycloserine after completing the pre-treatment evaluation. He was tolerating ATT. He has been discharged with all oral regimen, and he was advised to continue ATT for the 18 months. This was one case we'd like to bring you to notice, where in case we disseminated TB, we should not start on BPaLM. Better we consider all oral since the case of extensive disseminated tuberculosis.
The case of cervical as well as mediastinal lymph node involvement, the cervical pus has been positive for MTB and the RIF resistance has been detected. And the LP and MGIT, it's ongoing. We have not yet get the reports. So anyway, it is involved, considered as a disseminated. We started on all oral longer regimen for comments.
So,
Yeah, over to you, Dr. Alpa.
so what was in gene expert, what was it say? Was it low, very low, or medium? And are we using normal routine gene expert or gene expert ultra?
Routine gene expert, which showed MTB detected low.
Low. So I mean, LPA it would not detect. So just, I mean, what is done, that's correct. But anything probably soon we might have expert XDR available. And in expert XDR, even with the, smear negative cases, we may be able to get upfront fluoroquinolone and second line DST sensitivity. So in that, and INH, isoniazid, and ethionamide. So that in these type of cases, if it's medium or even low, you may be able to detect it through expert XDR. And then if we have upfront FQ resistance available, then that would help us to design the regimen in this kind of. So I think that was the only comment now.
Yes, Dr. Alpha, I think this is a very important comment that in this case, when we are starting the all or longer regimen, if we have the luxury of expert XDR, definitely it will guide us about the fluoroquinolone resistance. Otherwise, even LP, I think in this case, as you said, it is low. It may be the smear may be negative, so we'll have to go for culture followed by LPA and all this. That is one aspect. Second, which I want to sort of discuss and ask others also. You see, currently, because of the lack of international experience, the BPaLM is not being given in cases who have bone and spinal TB, meningeal TB, CNS TB, or disseminated TB, TB involving more than one organ. But you see, these conditions where they have cervical lymph node and mediastinal lymph nodes. I think, and this is the commonest extrapulmonary manifestation in our country. If you take into account, this and the pleural effusion are the commonest. So I genuinely feel that maybe in an operational research mode, such type of cases in the COEs, the Center of Excellence, they may be given this BPaLM regimen, and we follow them up strictly and then see what has been the outcome. That's what I personally feel. It may not be taken in an official statement, but these are the cases where we may try BPaLM under an operational research and then see the outcome, and then we can guide the country. That is my Dr. Alpa, what do you feel about it?
I would fully agree with Dr. Singha, because though by definition this becomes disseminated because of two-site involvement, but cervical lymph node, yes, and lymph node. I think these are the cases we definitely should give them a trial of BPaLM. I mean, as part of operational research, and they are likely to do well compared to the other disseminated form of disease like miliary TB or extensive CNSCC. So I fully agree with you.
Thank you.
Sir, thank you for that, sir. Suppose if we start a regimen like that, and is there any ethical concerns, sir? Since the guideline is not given to initiate the regimen for BPaLM, if any ADR has been happening, is there any ethical concern will fall on us, sir?
So, Dr. Weiss, let me clarify. In this case, we will give all or longer regimen. We will follow the national guidelines. My only suggestion and discussion was that if the CTD agrees and there will be a protocol committee, we may start an operational research in these type of cases. We may have a committee which will decide the protocol, and then they will be enrolled and they will be followed up. But definitely in this case, or in such other cases also as of today, we'll have to go for the all or longer regimen instead of BPaLM regimen as of today.
Thank you. Just one thing from ethical point of view, I don't think there is much concern about the ADR part of it. It is more whether patient would do well on this regimen or no. That is the only thing, because the guidelines don't say. I mean, I'm sure they are not likely to have more ADRs compared to other cases that we select. So it's just treatment response point of view, the ethical consideration may be there.
Thank you.
Thank you. Thank you, sir.
Thank you, sir. Excellent presentations and excellent cases, and a big learning from today's cases. At least I learned a lot. So thank you, Dr. Alpa and Dr. Singla. So I would just like to summarize, and maybe somebody can add if I'm missing on to something. What we discussed today was that more or less most patients with RIF resistance can be started on BPaLM regimen. We saw some of the x-rays were really bad, but still they've been started on treatment and they are doing well so far. However, we have to keep a watch on ADRs, especially the anemia and the neuropathy. Ensure that the midget and LPAs are done for all the patients, including the TNGS. It should be done and collected for every patient. Proper drug history to be taken before starting the treatment. Keep a strict watch on baseline reports that are coming, especially second line LPA and midget and TNGS. And then most cases that we discussed today were smokers and alcoholics. So we have to keep a watch on their follow-up LFAs and KFTs. They should be kept under strict watch. And since most of them had, a lot of damage, lung damage, so post-treatment sequelae is something that we have to keep a watch for. So we have to look in for rehabilitation and nutrition for these patients. Apart from what DBT and food baskets we are doing, we should make extra efforts for these patients. Also, some of the salient points that came up during the discussion was that yes, bilateral extensive pulmonary TB patients can be started on BPaLM regimen. Adult patients with weight less than 30 kg are eligible for the regime, and HIV is not a contraindication for the BPaLM regime. So these were some of the learnings that I noted down. If I've missed something, somebody can add. So with this, I would now request Dr. Ashok Bharadwaj to give his vote of thanks.
So thank you. Thank you.
And always there. Thank you so much for joining every time, every clinic.
So thank you, Nita. Thank you very much. Related to BPAR regimen, so I was given responsibility for the taking training in all 8 medical colleges in the state. So today is the second medical college, AIMS Bilaspur. So the set, that is why I wrote to you that I will join late. So 8 cases which were discussed today. So they were all, I could not listen all these cases, but they were all interesting cases. So hope, because this is a path-breaking regimen, though it will totally transform the management of DRTV in our country. So I will request all who have joined from the state TB cell, please saturate this capacity building in all medical colleges in the country so that we can fast track this regimen, because all till we have the capacity building of all, the CTD will not give the drugs. So please initiate treatment for BPAR regimen in biology so that the patient can have the benefit of this newer guidelines and the regime. So thank you for giving me a chance. Thank you, Nita.
Thank you so much. There is a feedback link on your chat box and on your mails. So kindly give us your feedback, and your feedback will be taken up seriously and we'll try to improve. Thank you so much. Thank you for joining. Thank you, Urvashi ma'am, Dr. Manpreet, all the people who have attended. Your attendance keeps us going. So please join every clinic that we do. Thank you so much. Thank you.
Thank you, Dr. Thank you.
Thank you.
Thanks to you also.